Welcome to the next session, Neuro-Ophthalmology session, Amazing Neuro-Ophthalmology. We have with us Dr. Kausalya Ma'am, Senior Consultant, Madura Arvind Eye Hospital, and Dr. Srilega Ma'am, Senior Consultant, Chaitanya Eye Hospital, and Dr. Mahaleshmi, Consultant, Balaji Medical College. And myself will be starting with the first topic, that is Amazing Neuro-Ophthalmology. We'll see how the neuro-ophthalmology is amazing. Neuro-ophthalmology is a specialty which deals with eye, brain, and rest of the body. So we'll see how this connection between the eye, brain, and rest of the body making this specialty. It's a subspecialty of neuro-ophthalmology is amazing. Case 1 is a 24-year-old female who is a housewife with complaining of sudden vision loss, both eyes, 1 month duration, was referred to us from the neurologist to find out cause of vision loss. Her complaints actually started 6 months back. Old documents showed right eye 612 parts and 66 parts vision in left eye. The older documents already it's there. Bilateral disc edema was documented. She was on top Diamox. On presentation to us, her vision was doubtful light perception both eyes, extraocular movements, abduction limitation was present, pupil sluggish reacting, fundus both eyes, pale disc with edema. Then we thought what to do next for the diagnosis. This is the fundus picture. You can see pale disc with edema and multiple hemorrhages, and the OCT RNFL also showing increased average RNFL thickness. And so we proceeded with the USG-B scan because disc is pale. We don't know pallor of the disc due to bilateral atypical optic neuritis or disc edema is due to extensive gliosis. So we proceeded with ultrasound B scan. It is showing our average means optic nerve sheath diameter 5.61 right eye and 5.09. In Indian population, the ONSD is around 4 to 4.5. This is definitely increased. So we proceeded with VEP. The VEP was not a flat one, waveforms present but abnormal waveforms. So we came to the conclusion that vision is there, but the cause of vision most probably fulminant IH. So immediate surgical management referred, and they did from tertiary center, ONSF and shunt both done. Post-op vision 1 meter left eye and hand movements in right eye. 1 meter vision is not a great vision, but she is able to see her now she is able to see her daughter. That is a great thing, from doubtful PL to 1 meter counting finger vision. And the follow-up visit, this is the disc appearance. Edema resolved, gliosis over the disc present. OCT RNFL you can see borderline thinning, and on left eye there is global thinning. And B scan also showing 4.23 is the right eye and 4 in left eye, that is ONSD. Fluid has come down post ONSF. So think here to highlight ultrasound B scan. If the discs are pale, increased ONSD help us to get an idea about cause of vision loss and type of optic atrophy. So how will we decide how to proceed, which eye we should select for ONSF? We have there is a test called 30-degree tilt test with the ultrasound B scan. You can see that here there is perioptic CSF space widening is here. When we ask the patient to change from her position from primary gaze to the 30 degree towards the side, you can see this perioptic CSF space width has come down. That is positive, more than 30% reduction in the perioptic CSF space. It's a positive tilt test or positive tilt test. So we can decide fluid is there, and we can proceed with ONSF. And ONSF usually with eye with poor vision we used to select. Then how to do ONSF? This is a ophthalmologist approach, that is medial conjunctival approach. We used to disinsert the medial rectus muscle. Disinserting medial rectus muscle. Then you can see the pearly white optic nerve. You should nicely retract the tissues and orbital fat from there. and gush of fluid confirms that you are in the perioptic CSF space. The most easy approach, and you can reattach the medial rectus muscle. Case 2, this is a 13-year-old girl. She is a sibling, known case of congenital fibrosis. Her mother used to bring both these children all the time. Her elder sister has congenital fibrosis, and mother always asks the younger, she is normal now, but will she get this squinting and abnormal head posture and all? But we used to reassure her the problem with the elder one is a congenital thing, and the younger one is perfectly normal. She will be normal. She won't get such a problem. But one day we got a call from her mother, and she told younger daughter also got sudden onset deviation of eyes. Doctor, you told the other elder one's problem is a congenital problem, the other one will be safe, but today she had sudden onset squinting. And we asked her to kindly send the photograph, external photograph. She sent the photograph. Here you can see the left eye, the abduction is limited, eye is ESO deviation is there, and she also gave history of double vision, and there is no history of seizure, limb weakness, no history of trauma. But we asked her, kindly send her, we need a fundus examination. The mother was irritated. She told it's difficult to bring her, but means compelling her, she brought the child next day. This is a fundus picture, the extensive papilledema. So repeat questioning, baby told that baby revealed she had head trauma 1 month back, and she didn't inform that to the parents that time, and she had 2 times headache and vomiting. Locally consulted, doctors gave some antiemetics and sent her back without further examination. So MRI revealed subacute SDH at right frontoparietal temporo-occipital convexity, and immediately she underwent emergency right FTP craniotomy and evacuation of subdural hematoma. Case 3 is a case of unilateral disc edema, 50-year-old male patient. He is a non-case of dendritiform cell carcinoma. He was on chemotherapy, complaining of acute, subacute progressive vision loss in right eye. On examination, unilateral disc edema with extensive hemorrhage was present. Vision 660, both eyes dropped to 1 meter counting finger in right eye in 1 week, and left eye vision was normal. Pupil RAPD was present. Disc edema present in right eye on fundus examination, left eye normal. You can see the disc appearance, the hemorrhages, and extensive elevation of the disc from the peripapillary retina. Then patient was referred from RCC. Then RCC people told we took MRI, and MRI was normal. We told MRI cannot be normal. This particular appearance is in favor of optic nerve head infiltration. We repeated the MRI with contrast, which confirmed optic nerve head infiltration. Now patient is on radiotherapy because optic nerve infiltration is a sign of CNS involvement. Case 4, 26-year-old female. She is an optometrist complaining of flashes and blurring of vision in left eye, 1 month duration. Her best corrected visual acuity, right eye 6.6 N6, left eye 6.6 parts and N6. CSF, she had this is her fundus appearance. She had unilateral disc edema, extensively evaluated by unilateral IH, and some neurologist advised her even IVMB, suspecting unilateral optic neuritis. But her CSF opening pressure 18 centimeters of water, which is normal, and MRI brain and orbit inconclusive, which or MRI brain and orbit normal, and VEP inconclusive for neuritis. So this is her fields. You can see blind spot enlargement and some scattered scotoma inferiorly. So we decided to observe her because we have to rule out other causes, retina local causes like acute idiopathic blind spot enlargement. We did a follow-up, close follow-up, and after 1 month her disc edema has resolved. That may be probable acute idiopathic blind spot enlargement. Pale disc case 5 is a pale disc evaluation. We will see how important pale disc evaluation. This is a 47-year-old lady, non-case of high myopia. noted defective vision in her left eye recently. Locally consulted and was diagnosed as vision loss due to glaucoma, since the other eye has also subnormal vision. She was referred to us, was on treatment for open angle glaucoma both eyes at time of presentation. Best corrected visual acuity 618 N8 right eye, left eye light perception only, mild ptosis in left eye and minimal adduction limitation in left eye, pupil anisocoria, left eye more than right eye. Fundus examination, pale disc both eyes, left more than right with cupping, but pallor was more than cupping. This is a fundus picture. Cupping is there, pallor is there, myopic changes are there, the OCT RNFL, global thinning in left eye. Then we decided that the appearance, external appearance is in wave pro, partial third nerve, pupil involving, pallor more than cupping and loss of vision in one eye. Decided to image the patient. Then we found compressive optic neuropathy due to IC aneurysm. This is a field. It's a case of compressive optic neuropathy. This is also 3D reconstruction. Okay. Thank you. Next, I invite Dr. Srilekha ma'am. She'll be talking OCT Neuro-Ophthalmology and emergencies in neuro-ophthalmology.
That was amazing, Dr. Gemini. Neuro-ophthalmology is one field which not only deals with the vision of the patient, but also deals with the life of the patient. So even a small amount of suspicion will save the life of a patient. So even early optic neuritis, early disc edema, early papilledema should never be missed. The primary doctor who sees the patient is the God for the doctor. So we can overdiagnose in neuro, but never underdiagnose. Amazing case presentation and very good cases. Thank you, Dr. Gemini.
Good morning. So I'll have two sessions today. First, I'll be discussing on OCT changes in neuro-ophthalmology, followed by emergencies in neuro-ophthalmology. So OCT changes in neuro-ophthalmology, I'll be discussing and following headings. These all parameters will be coming into shortly. The peripapillary retinal nerve fiber layer shows thickening in disc swelling, followed by quadratic thinning in the setting of optic atrophy. Here you can see the normal peripapillary retinal nerve fiber layer falling within the green area graph, whereas below you can see a case with a bilateral disc edema, papilledema showing thickening. That is the line is going above the green area. That is peripapillary thickening. But peripapillary thickness does not correlate with the visual acuity or the visual fields. That will be coming into shortly. Macular ganglion cell layer thickness, thinning is often the first sign of afferent visual pathway damage, and unlike RNFL thickness, it correlates with the visual acuity and visual fields. Then we can have small microcystic changes, that is microcystic macular edema in the inner nuclear layer in axonal degeneration, but these are non-specific changes. Another parameter is the optic nerve head volume. And this volume has more correlation with the Frison's grade of papilledema, and a cutoff of 3.97 millimeter cube is taken. And here this figure depicts increasing optic nerve head volume with increasing grades of papilledema. Another parameter that we can look into is the peripapillary retinal pigment epithelium Bruch's membrane angulation at the optic nerve head opening. And in the normal case, it is directed away from the vitreous in the form of a V shape, whereas in this swelling, you can see that it is angled forwards into the vitreous cavity in the form of an inverted U shape. And with the resolution of disc edema, it will come back to the normal V shape pattern. Optical coherence tomography angiography is useful in assessing the peripapillary radial capillary network that is not visualized on fluorescein angiography. And here you can see OCTA in a case of anterior ischemic optic neuropathy of the right eye, where you can see the flow voids in the temporal part of the optic disc and the disc swelling on the OCT B scan and normal left eye vasculature. Another thing is enhanced depth imaging OCT and KSOS OCT. These help us to image the deeper layers of the optic nerve head, such as a buried disc drusen. Now coming to clinical applications. Here, B-scan ultrasonography helps to pick up calcified drusen in the form of hyperechoic area at the optic nerve head like this, but it cannot pick up non-calcified ones. In such cases, we can go for the EDI OCT, which demonstrates these drusen lesions as a hyporeflective core lesions with a hyperreflective margin. And sometimes in swollen disc, you can also come across peripapillary hyperreflective ovoid mass-like structures like these, the so-called POMs, which is generally peripapillary axonal distensions. It's a non-specific and can be seen in any case of disc swelling, including papilledema. And optic disc drusen in fundus autofluorescence appear as bright specks. The superficial drusen appear as bright specks on the fundus autofluorescence image. In papilledema, other than this RNFL thickness and ONH volume, OCT also is helpful in demonstrating macular fluid, that is subretinal macular fluid or choroidal folds, as a cause for defective vision, because these are generally reversible. And this GCL thickness can also distinguish papilledema from pseudopapilledema. As you can see here in papilledema, here you can see the temporal aspect GCL thinning, whereas in pseudopapilledema it is uniform thickness all around. This is a case, a young female 33-year-old diagnosed with IIH and papilledema, and she had initial disc swelling with a progressive thinning of RNFL over time. However, you can see that there is with the treatment, there is an expansion of the visual speeds. In spite of the gross thinning of the RNFL, the fields are getting better. That is why it's not correlating with the visual fields. In optic neuritis, there is in the acute stage, there is elevation, there is increase in the RNFL thickness, and followed by temporal RNFL thinning around 2 to 3 months later. However, there's an OCT floor effect, and the general mean thickness of does not fall below 30 micrometer in spite of severe optic atrophy. Macular ganglion cell layer is more sensitive and reliable index of acute neuroaxonal injury and shows changes early, even about 2 weeks after the onset. This microcystic macular edema can be observed, and in multiple sclerosis, it indicates disease activity and worse disability. Neuromyelitis optica causes increased thinning of RNFL and GCL compared to multiple sclerosis, and this more predominant in the inferior and the superior quadrants than the temporal quadrant. Here we can see a 26-year-old female with a defective vision, gross defective vision in the left eye due to emoji positive optic neuritis with a gross depression of the fields. You can see here this pallor of the disc, and she improved with IVMP, plasma pheresis, and immunosuppressives. This is case of a male patient with demyelinating old optic neuritis with optic atrophy in the right eye, showing diffuse thinning of the RNFL and grossly depressed fields as well as GCL thinning. In ischemic optic neuropathy, initially there is increased RNFL thickness and subsequent thinning within about 2 months, and the GCL shows thinning much earlier, even as early as 2 to 3 days after onset of symptoms. And the pattern of GCL involvement, such as this altitudinal pattern of loss in the superior aspects, goes more in favor of ischemic optic neuropathy, whereas a more generalized thinning all around is more in favor of optic neuritis. And in compressive optic neuropathy, OCT helps in diagnosis and monitoring compression as well as predicting the visual outcomes after decompression surgery. And the greater the RNFL and GCL thinning, the more poorer is the visual outcome. Here is a 6-year-old boy who's diagnosed a case of opticochiasmatic glioma with a right eye optic atrophy and a pale disc, and the left eye with a initial disc edema with a vision of 6/6 N6, but however a dense temporal field defect. And there is a, even though there is a atrophy, thinning of the RNFL over time, there is a gradual improvement, a mild improvement in the field following chemotherapy. Coming to toxic hereditary and nutritional optic neuropathies, here also in the early stages, there will be optic disc thickening and RNFL, there can be disc edema and thickening, whereas in the later stages, there is development of temporal thinning and temporal pallor. In glaucoma, OCT helps in diagnosing the thinning is more, because the arcuate defect thinning is more in the superior and inferior poles rather than temporal aspect. Whereas in vigabatrin, the thinning is occurring in the nasal, superior and inferior poles rather than the temporal aspect in other neuropathies. And OCT angiography helps to demonstrate reduced capillary perfusion around the optic nerve in demyelinating optic neuritis, as well as in ischemic and Leber's and hereditary cases. Here is a case of OCTA in ischemic optic neuropathy, where you can see the right eye, it's acute disc edema, left eye or previous episode optic atrophy. The right eye showing OCTA showing the supratemporal aspect flow void, whereas in the disc in the left eye, peripapillary capillaries are uniformly decreased. So in conclusion, OCT imaging has revolutionized the diagnosis, monitoring and prognostication of neuro-ophthalmic conditions. However, the images has to be critically interpreted, keeping in mind the imaging artifacts that comes into play. Thank you.
Excellent presentation, Dr. Srilekha. Very good documentation, and the pictures are also very clear, and you had an array of cases. Nice presentation. And to add a few, nowadays OCT is also useful in diagnosing Alzheimer's and Parkinson's disease also, and it is used by neurologists as well. Thank you.
Thank you. So now I'll be going into my next topic, that is emergencies in neuro-ophthalmology. So neuro-ophthalmology, as Dr. Gemini has already told us, it is amazing. It's a field that requires multidisciplinary coordination and care that we have already demonstrated here in our introductory speech. And neuro-ophthalmic emergencies can be life-threatening or vision-threatening, and many of these may require extensive ancillary testing. And these are the various diagnoses that may come into play that we will be going into shortly, and will be discussed under the following categories. And in history, take a history regarding the pattern of visual loss and examination regarding the visual acuity, color vision, the fields, the pupillary reactions, and the fundus examination. And the pattern of vision loss or field defect will give us an idea about how to localize the area of the lesion. And the anterior ophthalmic and fundus examinations will identify the most common ophthalmic causes of vision loss, such as in disc edema or optic atrophy or any other cause. And examine the pupils closely for any anisocoria, relative afferent pupillary defect, and look for other associated signs and symptoms, such as proptosis, ocular motility abnormalities, sympathetic pathway dysfunction, focal neurological deficits. And these are some of the causes of acute vision loss that we'll be coming into now. The first among these, giant cell arteritis causes arteritic antidischemic optic neuropathy with unilateral sudden vision loss and with a great risk of fellow eye involvement. The ESR and CRP are raised, and fundus fluorescein angiography shows choroidal hypoperfusion there, and the temporal artery biopsy is a diagnostic. And look for these systemic features in these patients. And urgent initiation of IVMP followed by slow taper of oral steroids may help to prevent recurrent ischemic events in these patients. And this is a case of GCA with pallid disc edema in the right eye and fellow eye old involvement with optic atrophy. You can see the disc edema here and the RNFL thinning here with the grossly depressed fields. In contrast, when you come to non-arthritic ischemic optic neuropathy, the discs look more hyperemic, and the sectoral pallor of the superior aspect you can see here with a corresponding typical inferior altitudinal field defect. Now coming to pituitary apoplexy, these patients can present suddenly with a painful ophthalmoplegia, vision loss, and bitemporal field defects. And they may need a corticosteroid supplementation. This is a case of coming to papilledema cases. A 25-year-old female for a routine eye examination found to have papilledema, and she was diagnosed as having idiopathic intracranial hypertension. And the previous case, she had good vision, 6/6 and 6 vision, normal fields, normal, this color vision, visual function was normal. However, this is again another case of idiopathic intracranial hypertension. You must be remembering the pictures from Dr. Gemini's talk. This is the same case. She was not that fortunate enough. She had fulminant intracranial hypertension. She presented with a hand movements vision with a RNFL, initial pallid disc edema with a peripapillary hemorrhages and the disc edema RNFL thickening, and there was an increased ONSD diameter in ultrasound B scan. And she underwent optic nerve sheath fenestration, following which there is a resolution of disc edema and peripapillary hemorrhages. However, there is a thinning of the RNFL, and there is a marginal improvement in vision from hand movements to counting fingers. So papilledema can harbor some other things other than idiopathic. So this is a 13-year-old girl who was referred to us with a defective vision, headache, and referred as bilateral optic neuritis. And she had a papilledema in both eyes, and on evaluation she was found to have a grossly depressed fields more in the left eye, and neuroimaging revealed tectal plate glioma, and vision improved after neurosurgery. Now coming to optic neuritis cases, it's a 31-year-old female with multiple sclerosis optic neuritis. In the left eye there is mild disc edema with a grossly depressed fields, and she improved following IVMP therapy. This is another 42-year-old male patient with right eye defective vision and found to have papillitis, and there is a central cecal scotoma with abnormal pattern VP, and he also improved after IVMP treatment. So optic neuritis can be different, have a different spectrum, such as emoji positive optic neuritis, which are more common in children. In multiple sclerosis occur in 20 to 40 years age group, and NMO may be a little bit later, like 4th or 5th decade. And coming to the compressive lesions, the compressive optic neuropathy can be close to the eye, such as in the orbit, such as in thyroid eye disease, such as here, or optic nerve glioma, or it can be higher up, such as in the case of 11-year-old boy with a defective vision in both eyes, and on examination found to have temporal pallor of the disc. And there is a field defect with a left grossly depressed, right is showing a temporal pattern, and the RNFL is also thinned out, and he was diagnosed as having craniopharyngioma, and the fields improved after neurosurgery. And here there is a 35-year-old myope patient who came for a change of glasses, lady, and on examination she was found to have temporal pallor, and fields showed a temporal pattern, bitemporal pattern of defects, and imaging, on further imaging she was found to have opticochiasmatic glioma, and her vision improved following decompression surgery, partial debulking, but the fields are remaining almost static. Coming to some other toxic optic neuropathies like methanol poisoning, here the vision loss is believed to result from interruption of mitochondrial function in the retronamellar optic nerve. And in ethambutol optic neuropathy, the optic nerve appears normal initially with a normal RNFL, and with subsequently there is thinning, temporal pallor and temporal thinning of RNFL. Another situation is traumatic optic neuropathy, which can be either direct or indirect trauma, and patient can present with a vision loss and RAPD, and these may require IVMP treatment. One other category is transient monocular vision loss. This can be either due to thromboembolism, hypoperfusion, or angiospasm affecting the occipital lobe or the visual pathway. And in these patients, look closely for fundus findings such as an embolic branch retinal artery occlusion or a central retinal artery occlusion. In occipital stroke patients, when we examine, they complain of defective vision, but the fundus ocular motility and pupillary reactions are normal, and the fields show homonymous hemianopia defects. These patients require urgent referral to a stroke specialist. There is a vision, regarding vision. Now coming to diplopia, that is ocular motility abnormalities, which can either be due to cranial nerve 3-4-6 palsies. You can have horizontal gaze palsy, internuclear ophthalmoplegia, or skew deviation, and look for the probable location of pathology as listed below. And orbital apex, you can have rare conditions such as rhino-orbital cerebral mucormycosis. Look for evidence of cavernous sinus thrombosis or intraocular aneurysm that Dr. Gemini beautifully described here, like a posterior communicating aneurysm, which can cause a pupil involving third nerve palsy without ptosis and aberrant regeneration. If the pupil is spared, it is most likely an ischemic third nerve palsy, and this resolves spontaneously within weeks. Otherwise, it needs surgical intervention. Other rare cases such as Wernicke's encephalopathy due to thiamine deficiency can also present with ocular motility abnormalities. Do carotid arterial dissection. So in conclusion, though being rare entities, a high index of suspicion should be there to pick up these neuro-ophthalmic emergencies, and accurate and timely diagnosis with a prompt intervention can be life-saving as well as sight-saving. Thank you.
Thank you, ma'am. That was an amazing talk about the emergencies in neuro-ophthalmology. Almost all conditions, common conditions and rare conditions, ma'am all described, and how to manage. And usually we think that ophthalmology is only dealing with the vision-threatening conditions, and when it comes to neuro-ophthalmology, rather than vision, mostly it is life-threatening conditions. You have to take double care while dealing with all the conditions of neuro-ophthalmology. Thank you, ma'am. Thank you.
Thank you.
Next, I invite Dr. Kausalya, ma'am, Senior Consultant, Madura Aravind Eye Hospital, Department of Neuro-Ophthalmology. I will be giving an interesting talk in endocrine disorders of neuro-ophthalmology.
Good morning, everybody. At the outset, I would like to thank Dr. Gemini, Dr. Bastin, and the organizing committee for inviting me here. This is an interesting topic and little unusual, endocrinological disorders in neuro-ophthalmology. So we'll cover few like what are the disorders of pancreas, thyroid, pituitary, and most of it will be a repetition what my previous speakers have spoken. So the human eye provides valuable clues for the recognition and management of many systemic diseases. So in neuro-ophthalmology, it's a beautiful field where you have to talk to the patient, ask history, and from the history itself, most of the diagnosis is made. And more importantly, systemic illness is very, very important. Many a times when you ask the patient whether you have diabetes or hypertension or a thyroid problem, patient will say no because they are under medication. But if you ask like what all medications are you taking, then they will pull out everything. So that's how we get misguided. So why the systemic illness is more important is based on systemic diseases, and because of systemic conditions, we get many neuro-ophthalmologic diseases. So this question, like if there are any students over here, are you on any medications? That is the only, that is the most important question you have to ask all your patients. So we'll go to the pancreas first. And diabetes, as we all know, India is becoming the diabetic capital of the world, and this is a leading cause of blindness among adults. And it leads to a lot of micro and macrovascular abnormalities. Nothing is new here, all of us know. So what are the common conditions which diabetes, like whenever we speak about diabetes, everybody knows about diabetic retinopathy, but only very few people know about anterior ischemic optic neuropathy. This is one condition we have to know because most of the times it is misdiagnosed as optic neuritis, and many a times steroids are given for this, where steroids are contraindicated. So this we have to know very clearly. See, 90% of the patients have diabetes. When I was a student, it was most commonly due to hypertension. We'll ask the patients like, did you take any antihypertensive medication during bedtime? That will be the common question. And while getting up, the patient will be losing the vision. But now the picture has completely changed because of the rampant diabetes all over. Even patients from villages, from the rural side also, they have diabetes, and we are seeing at least one patient per day in our neuro-ophthalmology clinic in Madurai. So that is little disheartening, but a high degree of suspicion, and we have to be really careful in diagnosing this because the treatment is completely different from optic neuritis. So these patients will have sudden onset, painless, and monocular vision loss. Why I am saying monocular is this is a sequential condition. This is not a simultaneous condition because optic neuritis may be bilateral simultaneously, but usually AON will be sequential. One eye will get affected first, followed by the other eye, and the onset will be sudden, and it will be always painless. That is another clue over here. So if the patient says acute onset, painless, then it is mostly AON. So when you see the color vision will be defective, and central fields, there will be altitudinal field effect. If you can see here, this altitudinal field effect is very typical of AON, and anywhere else we will not see this type of field effect. So this is very important. And the fundus, if you see, there will be pallid disc edema, pallor plus edema because it is due to ischemia. So diabetes is strongly associated with AON in younger patients, and always there is a risk of AON in the fellow eye. So we have to keep a watch on them regularly, and we have to tell them to strictly control diabetes and look for complications in the other eye. And one more thing in the other eye, what we have to see is crowded optic disc or disc at risk. So disc at risk, this is the crowded optic disc or the disc at risk, where there will be a small physiological cup and elevation of the disc margin with a thick RNFL. So if it is there, definitely that patient is going to get AON in a few days or months or years time. So we have to inform them to be very, very clear about strict diabetes control. So, and all of us know about nerve palsies. The most common cause for sixth nerve palsy, third nerve, pupil sparing third nerve palsy is diabetes, and abducens nerve is the most commonly affected nerve. Any new onset double vision, here you can see the sixth nerve palsy with abduction restriction. The spontaneous resolution occurs within 8 to 12 weeks only with the control of diabetes. So all of these patients you have to ask to for main investigation is HbA1c, because most of the times we do random blood sugar and it comes as like 130, 135, and you think the patient is not a diabetic because that patient will be not a known diabetic. You check the blood sugar in the clinic and it will be around 130, 135, and if you check the HbA1c, it will be 9 or 10. So we should not be missing diabetes just by doing a random blood sugar. So please do HbA1c for all your patients where you suspect diabetes. That is very important. And in all cases of sixth nerve palsy, nowadays we are doing MRI with MR angiography. As my previous speakers have spoken, Dr. Gemini and Dr. Srilekha, aneurysms. ICA aneurysm is one of the most important cause of sixth nerve palsy. So MR angiogram is a must. And another thing is sixth nerve palsy is otherwise called as tumor nerve, so we do imaging for all the patients. And third nerve palsy is another cranial mononeuropathy which is common due to diabetes, and usually it will be pupil sparing. This is because of increased duration of diabetes, uncontrolled glucose levels, and advanced age of the patient. And this is very important, cavernous sinus syndrome or the SOF syndrome, where there will be multiple cranial nerve involvement. 3, 4, 6 will be involved. Along with this, if second nerve is also involved and the vision is lost, then it is called orbital apex syndrome. I'll take few more minutes. Yes. And diabetic papillopathy is also another interesting condition where it is seen in uncontrolled diabetes. So I just want to emphasize about this condition. These patients will complain of mild blurring of vision. And if you check the vision, it will be 6/6.
And if you check the fundus, there will be mild disc edema with mild hyperemia. Everything will be mild. And if they control the diabetes, everything will fall in place. So it should not be mistaken for any optic neuritis, and we should not be in a hurry to give IV steroids. So coming to thyroid related ophthalmopathy, because of the increase in the thickness of the muscles and increase intraorbital pressure, there will be compressive optic neuropathies. And the most important thing what we see in the neuro-ophthalmology clinic is ocular myasthenia. So in all cases of ocular myasthenia, thyroid function test is mandatory along with the CT thorax to rule out thymoma, another endocrine abnormality. And the most important thing is idiopathic intracranial hypertension, which is very common among obese women. And nowadays, hypothyroidism is very much prevalent. Overweight and obesity is becoming another epidemic in our country. So we are seeing a lot of patients of IIH nowadays compared to some 4 or 5 years back. So all patients who are overweight or little obese, younger age group women, we have to suspect IIH. Definitely do a thyroid function test, which comprises of T3, T4 and TSH. And for all the patients, along with MRI, venogram is also mandatory to rule out CVT, that is cortical venous sinus thrombosis. And initially we give or treat with oral acetazolamide tablets, and if it is not improving, lumbar puncture and further management. So just one patient, a 54-year-old male with the right eye defective vision since 1 week. Visual acuity was 660 in the right eye and left eye 66, and right eye showed RAPD. Fundus was almost normal. And there was an altitudinal field loss in the right eye. And we did MRI brain because there was a sudden, means it was an unexplained vision loss. But the MRI showed diffuse white matter changes. Nothing, no tumor, no optic neuritis, nothing. So it was a different picture. And finally, we came to know that the serum calcium levels were low, and the patient also had neurological deficits like difficulties in initiating speech, occasional double vision, cramps, all those things. So this calcium gave us a clue towards the diagnosis. It was optic neuritis secondary to primary hypoparathyroidism. This entity also exists. So in all cases of optic neuritis, please have a suspicion of this also, and please do serum calcium levels as well. And again, not only optic neuritis, papilledema also can be caused by hypoparathyroidism like hypothyroidism. That is again because of the increased CSF production. So in cases of unexplained papilledema or optic neuritis, please check serum calcium levels. And pituitary tumors. We have a lot of pituitary tumors, and pituitary adenoma is the most common intracranial tumor which cause any neuroophthalmic manifestation. Initially, the patient will be having temporal pallor with bitemporal hemianopia, and if not treated, the tumor will grow, compress more, and will end up in primary optic atrophy. So this can be a secreting tumor or a non-secreting tumor. Here you can see the sella, and here you can see the pituitary tumor which is compressing the sella and the chiasm. So this is a short video showing how pituitary tumor enlarges and compresses the optic chiasm. The tumor is growing and compressing the optic nerve. So the most saddening part in this is, this is a preventable blindness. Many patients, they come to us very late, and so we are not able to save them. So if they come early, and if we can diagnose early, then this blindness can be prevented. Even a mild temporal pallor, please take it from me, do not miss it. Do a MRI brain to rule out any cellular or supracellular tumor. And based on the MRI findings and other things, we can plan the management. So, and pituitary apoplexy is an emergency condition which occurs in pituitary tumor. Here you can see the hemorrhage or infarction of the pituitary gland in a pre-existing pituitary macroadenoma. These patients will have severe sudden onset headache and vision loss with extraocular nerve palsies. This will be an emergency condition again, like GCA. So this is another interesting patient we had in our OPD, a 45-year-old male. He was from Nepal. He was working as a Gurkha in Madurai. And he had sudden onset of headache and vomiting of 10 days duration with diminution of vision in both eyes of 1 week, along with drooping of the eyelids. He was brought by his relative, and if you see, the vision was very less in both eyes, PL plus and 1/60, with complete ptosis with complete restriction of the movements in both eyes. We just did a MRI and it showed pituitary macroadenoma with apoplexy, and he was immediately shifted to a neurosurgery facility and he was operated and he recovered. Another interesting thing and most important thing as for all women is Sheehan's postpartum necrosis. There is the pregnancy increases vascular risk, and we all know ischemic necrosis of the gland is induced by a postpartum condition, and there will be lack of lactation and all these things. And MRI brain, if you do, you can see a posteriorly compressed pituitary gland and a partially empty cella. And another most important thing is metastasis. In neuro-ophthalmology, metastasis also plays a very crucial role. Many a times the patient comes with a nerve palsy or any other optic neuritis kind of a thing, or mild temporal pallor, and when we do a imaging, there will be secondaries in the brain, and if we search for the primary, that your radiologist will find out some tumors, some cancer sitting in the lung or a breast or somewhere else. So metastasis is also very common nowadays, and depending on the primary malignancy, the management varies. And many genetic disorders also can have such manifestations. To name a few, multiple endocrine neoplasia, neurofibromatosis type 1. These patients will have optic nerve head glioma. This is very important. My previous speaker had given a beautiful history about these patients. And Wolfram's syndrome is another thing. Didmovat syndrome, we all know. Diabetes mellitus insipidus, along with optic atrophy and deafness. And another one is Kalman syndrome and McKeown-Albright syndrome. And this is Kearns-Sayre syndrome. This is very common in our OPDs. The patient comes with external ophthalmoplegia, pigmentary retinopathy, and there will be a mitochondrial myopathy also, and the patient has to be investigated for cardiac conduction defects. And this is a congenital condition, septo-optic dysplasia with optic nerve head hypoplasia. And few adrenal conditions also can have neuro-ophthalmic manifestations. Horner syndrome is such a thing. This is due to neuroblastoma. So in conclusion, knowing these ophthalmic manifestations helps in early detection, prevention, diagnosis, and management. We can significantly reduce the morbidity related to these disorders, including permanent visual dysfunction. Just suspicion is needed for us. And main thing is history taking. History is everything in neuro-ophthalmology, so please talk to the patient. 90% of the diagnosis can be made with the history alone. And the remaining 10%, we have to do clinical investigations. And MRI, neuroimaging, all other investigations just contribute for 2 to 5% only. Thank you for the opportunity.
Thank you, ma'am. Thank you very much for the excellent talk. That itself on a rare topic, endocrine disorders in neuro-ophthalmology. Your talk actually enlightened us also. Usually in endocrine disorders, we think about thyroid and pituitary lesions, and parathyroid and other even pancreatic lesions also can produce multiple endocrine, means neuro-ophthalmological conditions. Thank you for enlightening us, ma'am. Next, I invite Dr. Mahalakshmi for the topic, what is new in neuro-ophthalmology? Over to you.
Good morning, everyone. My topic today is what's new in neuro-ophthalmology. So we'll be dealing with the recent advances in neuro-ophthalmology. So neuro-ophthalmology has evolved in the specialty in the recent past due to the newer diagnostic and therapeutic modalities. So the clinical relevance are OCT, gene therapy, serology markers, drug molecules, teleophthalmology, and artificial intelligence in the field of neuro-ophthalmology. In IIH, idiopathic intracranial hypertension, you mainly see the recent advance is that you have to find out the optic nerve head volume analysis. It is adding volume to the to other parameters like RNFL and total retinal thickness. It's significantly increased in early papilledema, but there are minimal changes in GCC. So there is only visual acuity and visual fields are showing minimal changes, corresponding to the minimal changes in the GCC. While increased RNFL thickness also has a positive correlation with increased intracranial pressure in IIH patients. And optic nerve head volume analysis is measured between the Brooks membrane and the internal limiting membrane by superimposing a ETDRS grid. So this is a picture of spectral domain OCT image showing chronic papilledema with the increased RNFL thickness and GCC thinning, and there's also a clinical picture of a chronic papilledema. Other entity is pseudopapilledema, where you'll see three main entities, which is foams, which is peripapillary hyperreflective ovoid mass-like structure, which is non-specific. It's also seen AION. And other causes of pseudopapilledema are optic disc drusen and horizontal hyperreflective lines. There's a study which shows that even if the RNFL thickness is less than 158, even without neurological signs and symptoms, it is suggestive of pseudopapilledema. But author also suggests that you do a serial OCT imaging for at least 6 months, and EDI and SSOCT is recommended for diagnosis of optic disc drusen. In case of optic atrophy, you measure, the recent advance is that you can measure along with RNFL and GCC, you also measure the minimum rim width at the Brooks membrane opening. So it differentiates glaucomatous and non-glaucomatous optic atrophy. It's measured between the ILM and the Brooks membrane. And in case of multiple sclerosis, there is overall RNFL thickness. Along with that, when you see the VEP, there is no correlation because there's a structural loss but no functional deficit present. In neuromyelitis optica, there is GCC thinning and RNFL. There's also a study showing microcystic macular edema present in 13% of patients. In Alzheimer's disease, there's decreased retinal macular and choroidal thickness. Along with that, there is in early onset Alzheimer's, you find RNFL and GCC thinning present. Gene therapy, the LHON is the most common condition where gene therapy is used, where a reflex study is done where the visual outcome of treated patients appear to be better than what is in the literature, and treating the patient 6 months before the vision loss helps better than the after outcomes. In bilateral injection of intravitreal injection given is better than the placebo, leaving it alone, and improvement in gene therapy is sustained for about 5 years. The new biomarkers in neuro-ophthalmology is aquaporin 4 antibody. It's a biomarker for NMOSD, neuromyelitis optical spectrum disorder. Bilateral optic nerve and chiasm is involved. This posterior portion of the optic nerve is enhanced. In case of poor recovery, IVMP is crucial with plasma exchange. In case of relapse, immunotherapies are mandatory. MOG antibody is the another entity where you'll find that optic neuritis is the presenting feature with optic disc edema and pain on eye movements. MRI will show optic nerve enhancement, often extending to optic nerve sheath and periorbital fat. Corticosteroids are the early treatment for spontaneous recovery, and plasma exchange if steroids are not responding. In chronic relapsing patients, immunotherapy is suggested. Another antibody is collapsing response mediator protein, which is seen in paraneoplastic antibody. Most commonly, they are also accompanied by retinitis, vitritis, and iritis, and systemic steroid shows visual improvement. It's an overview of all the antibodies seen here. So typical features of these antibodies shown in aquaporin, MOG, and collagen protein. Here is a localization of visual pathway, where in MOG you will find that optic perineuritis is affected. In aquaporin, chiasm and tract, and multiple sclerosis, it's focal optic neuritis. Biomarkers other than myasthenia, other than AChR receptor, there is MuSK and LRP4. The new drug molecules that are seen are tocilizumab, where it's seen in GCA, giant cell arteritis, and IV teprotumumab for thyroid-associated orbitopathy. And in case of Exenatid is the new drug that has been developed for active IAH. Telemedicine, it's been higher up before starting from COVID-19 period, but it also limits decision making in secondary opinions and triage. Artificial intelligence in neuro-ophthalmology, it's there's a deep learning system where they feed the images of normal and the abnormal images, and you send the patient image and they give you the they detect the underlying neurological condition. There's something called brain and optic nerve study with AI, which distinguishes papilledema accurately and identified from trivial fundus images. However, AI cannot replace human physicians and it should remain as an assistive tool. Thank you, and these are my
Thank you,
references.
Dr. Mahalashmi, for the excellent talk on newer advances in neuro-ophthalmology.